Hello, I'm Christine Coppola, here to discuss Healthy People 2030 heart disease and stroke initiatives. Learning objectives. Number one, to understand the behavioral and risk factors for heart disease by comparing gender, age-adjusted age group, race and ethnicity, education attainment, and household income. Number two, to analyze the data from the CDC to the populations I listed above. Number three, to review a case study. And number four, to inspire and create some ideas for improving. Cardiovascular disease, or ASCVD, also known as, encompasses conditions such as coronary disease, coronary artery disease, congestive heart failure, peripheral vascular artery disease, and aortic aneurysms. Many of the same risk factors for stroke are identical to those with CVD. That's why we call it ASCVD, which is atherosclerotic cardiovascular disease. Conditions that increase your risk are high blood pressure, hyperlipidemia, diabetes, and obesity. Some of the behaviors that impact these conditions is high saturated fats and cholesterol diet, sedentary lifestyle, drinking too much alcohol, and tobacco abuse. The prevalence and trends data tools can be found on the cdc.gov website. We'll be reviewing the behavior risk factor surveillance system tools, or for short, the BRFSS prevalence and trends tools. So our population is going to be in Connecticut for the year of 2021. We're looking at heart attack and stroke topics, so we are looking into cholesterol levels. So the BRFSS tool looks at different risk behaviors and how different populations are affected. So we can use these tools to address health disparities. So our question, the question that was asked to people was, this is for adults who have had their blood cholesterol checked and have been told it was high. So we're working with that according to the CDC, age and sex adjusted rates here. Heart disease is the number one killer of both men and women. Heart disease can happen at any age, but the risk goes up with age, as you'll see in the next slide. And as you can see here in this slide, as we get older, more towards middle age and older adults, the answer yes for high cholesterol checks is higher. While the CDC informs us that race and ethnicity is important, and there are some information to be gleaned, but heart attack and stroke can affect anyone. Some groups are more likely to have conditions that increase their risk for cardiovascular disease. Heart disease is the leading cause of death for people of most racial and ethnic groups in the United States, including African Americans, American Indians, and Alaskan Natives, and white people. For Asian Americans, Pacific Islander, and Hispanic, heart disease is second to only cancer. Education does not appear to make a big impact on this graph. However, a study done by Tremblay in 2024 found that the lower income and educational attainment are associated with higher risk. Looking at household income and how it impacts cardiovascular disease. Lowest income has an impact, and it's probably most likely related to food insecurity. According to 2022 Center on Budget and Policy Priorities report, there was a correlation between supplemental nutrition assistance programs, or otherwise known as SNAP, and showed a substantial body of research linked to SNAP being able to lower the risk for heart disease and obesity among adults who had access to SNAP as children. So I guess that would be a retrospective cohort analysis. Second tier incomes, I wonder, looking at the that next level, how it kind of goes up a little bit after that really low poverty line. I almost wonder if it's like SNAP benefits, people aren't eligible, but yet they don't make enough money for good food yet until they get to the next income level, the third income level, where things start to go back down a little bit until we go back up higher in income. So again, interesting thing to consider is how people are eating and how that impacts and how they have access and food security. For the Healthy People 2030 campaign, we're improving with cardiovascular disease. I almost wonder if it's attributable to the better medications that we have out these days. I'm not really sure. I'm hoping that maybe it's primary prevention with better diet, exercise, mobility, that sort of thing. But I really do think that our medications have really come a long way in the last 10, 15, 20 years. But stroke deaths aren't improving. There's a decrease in the desired rate. I'm not really sure what we can attribute that to, but a lot of the same, as I pointed out earlier, a lot of the same interventions for coronary artery disease are the same for stroke. So this would be interesting to kind of drill into at a future date. So we have levels of prevention: primary, secondary, tertiary prevention. So primary prevention referring to preventing the disease before it occurs. This is getting down with the healthy lifestyles, screening for those that are 40 to 75 years old, a 10-year risk calculator to determine if you are a candidate for pharmacological therapy for LDL treatment. You want to consume a healthy diet. Exercise is important, 150 minutes per week of vigorous exercise and 2 days of strength training. That comes from the AHA, the American Heart Association. So with secondary prevention, it's a little bit more tricky. You want to detect things that are early and treat promptly. This would include those who have coronary artery disease, such as a myocardial infarction, stable typical angina, coronary artery stenosis that is greater than 50% on angiogram, cerebral vascular disease such as a TIA or a stroke, or carotid artery stenosis greater than 50%, symptomatic peripheral vascular disease, intermittent claudication, aortic stenosis, things like that, abdominal aortic aneurysm, and basically the goal with these are to target your blood pressures, below 130/90. Get the LDL below 70 for non-diabetics, and the European guidelines is below 50 milligrams per deciliter. In order to get there, a lot of times we're looking at your PCSK9 inhibitors. If we're not able to get to a LDL below 70 or 50 respectively. So that's your pro-protein convertase, subluxin, Kilton, type 9. That's an injection. That's going to work really well for most people to get that LDL down. SGLT2 inhibitors, that's your sodium glucose cotransporter 2s. We're using them a lot in cardiology because they improve, heart failure. It's a cardiovascular ASCVD risk reducer, and it actually helps with chronic kidney disease, which is another risk factor for coronary and stroke disease, right? So, and then we have tertiary disease. So this is basically, after the person has had a heart attack, this is to reduce the impact of ongoing illness. So think of cardiac rehabilitation after somebody's had a heart attack, or stents placed, medications like high-intensity statins, aspirin, maybe dual antiplatelet therapy. This is, also where we get into symptom management. We're working with patients to reduce their, angina burden, trying to make sure that they can get, to a good quality of life. So there's many different ways to start targeting that population. So I thought I'd give you a case study that is very similar to a lot of the patients I encounter on a regular basis. So this one is a 58-year-old male presenting to the outpatient clinic for a routine annual visit. On examination, his blood pressure was 146 over 88 millimeters of mercury and his BMI is 29. He is a current smoker. His lab results are hemoglobin A1C of 8.9%, which, as we know, is uncontrolled. Total cholesterol is 147, HDL is 54, which is actually not bad, and his LDL is 92. Spot urine albumin to creatinine ratio is over 300, indicating early kidney disease. He regularly takes lisinopril and hydrochlorothiazide. He's concerned about his mother's death from myocardial infarction at the age of 48. And the patient is looking for risk reduction strategies for future cardiovascular events, rightfully so, as he should. This is good motivation on his end. Other than emphasizing a healthy lifestyle and controlling the blood pressure and diabetes, which is absolutely primary, first on the focus, you would further manage this patient with medications. So are we going to do A, initiate simvastatin at 40 milligrams, B, initiate rosuvastatin 10, and add on 81 milligrams of aspirin, C, initiate atorvastatin 80 milligrams, or D, initiate rosuvastatin 40 and aspirin 81 milligrams. So the answer is D, and the reasoning behind that, and most people would say, well, look, he's got a LDL and it's under 100, so why are we being so aggressive? And by the way, why are we adding an aspirin? The reason for this is we want the high-intensity statin therapy because he has diabetes and he's got evidence of CKD, which is also another good indication. And because of his diabetes, that's kind of a equivalent for cardiovascular disease. So we can treat these patients more aggressively as long as there's not a bleeding contraindication. So something that I am actually particularly involved and interested in is utilizing digital health technology to improve cardiovascular disease, like text messaging programs, smart applications, wearable devices. So basically, because the cornerstone of cardiovascular disease management is based on the motivation of lifestyle changes, these devices can be very powerful in changing behavior and actually getting people up moving and doing things that they should be doing, diet recommendations, things like that can keep people on track. In fact, in 2019, the WHO recommends digital interventions and published some recommendations along those lines. That's a very big book of information. Anyway, those are some innovative ideas. The next few slides will reveal the references, and I hope that this was a valuable learning session, and thanks again for your attention.